Yeah, तभी तो email से हाँ email से किया फिर उसको
तुम्हारा क्यों किया
अभी तो उसी पे तो क्लिक उस पे डायरेक्ट भी हो जा रहा है
Dr. Ruben, are you joined with us? Dr. Ruben? One moment, faculty. He has some challenges. Let me sort that. Ajay Khanna sir, good evening, sir. Jayalal sir, good evening.
Good evening, good evening.
Good evening, Dr. Jalal.
Good evening, sir. Vastu sir.
Sir,
Nice
nice to meet you.
to see you.
Yeah.
Good evening,
Same
Dr.
here.
Jayalal.
Good
So
evening.
nice
Good
to
evening.
see you.
Dr. Ruben?
Good evening, sir.
Good evening, Dr. Ruben. Please introduce yourself, your unit chief, and share your presentation. In the meantime, I warmly welcome Professor Somprakash sir, Dr. Seema ma'am, Rahul sir, Khanna sir, Jailal sir, and other senior faculty here. Sahai sir is joined, and we expect other faculty to join shortly. Dr. Augustine and others. Dr. Ruben is from Government Stanley Medical College. He'll be presenting a case of mass abdomen today. Faculty, please take over. Please introduce yourself and start your PowerPoint.
Yes, sir.
Dr. Ruben, we are unable to see you.
Sir, good evening, sir. Am I audible?
Yeah, you are now perfect. Please go ahead.
All right, sir. My name
Good
is. Thank you, sir. My name is Ruben Toy. I'm a final year postgraduate at Government Stanley Medical College, Chennai. And I would like to thank my chief, Professor Dr. Satyapriya ma'am, for giving me this opportunity to present here. And I'd also like to thank my head of department, Professor Dr. Gayatri ma'am. So my topic is mass abdomen. May I begin?
Go ahead, go ahead.
So I have a 55-year-old male patient who's a farmer by occupation, Mr. G, and he hails from Chennai. He came with chief complaints of abdominal pain for a month and also lump in the abdomen for a month. He was apparently well 1 month ago, after which he complained of abdominal pain, which was in the epigastrium, dull aching, intermittent. It was not associated with any sort of food intake. There was no referred pain nor radiating pain, and there were no aggravating or relieving factors. He noticed a lump in the upper abdomen, which was large, and he did not find it to increase in size. There was history of early satiety, which was present after consuming just a cupful of rice, and this was followed by loss of appetite for a month. There was history of significant loss of weight as expressed by the patient by the loosening of his clothes for a month. There was no history of fever or night sweats, no history of flatulent dyspepsia, no history of vomiting, dysphagia, abdominal distension, obstipation or constipation. There was no history of yellowish discoloration of skin, sclera, mucous membranes, passing high colored urine or pale colored stools. There was no history of hematemesis, melena. No history of cough, chest pain, shortness of breath, hemoptysis, nor back pain or bony pain. And there was no other history of swellings in the body. He previously underwent an emergency laparotomy at MMC about 25 years ago, for which we do not have details. He's also a known case of coronary artery disease and hypertension, for which he's on medications regularly. He has no specific allergies to drugs or food. He consumes non-vegetarian diet. He has loss of appetite. His sleep, bowel, and bladder habits are unaltered. He was a previous smoker, and he also used to consume alcohol for more than 10 years. In terms of smoking, he had BD, a bundle of BD per day, and he would consume brandy, a quarter, 180 ml per day. There's no history of malignancy in his family or cancer-related death in his family. Now, I would like to summarize just the history. I have a 55-year-old male who's a farmer, a known case of coronary artery disease and hypertension, who has had an emergency laparotomy in the past, who now complains of abdominal pain in the epigastrium with an upper abdominal mass, with early satiety, loss of appetite and loss of weight, and a previous habit of smoking BD and consuming alcohol for more than 10 years, which is now stopped. I would like to proceed with the examination of the patient.
Dr. Rubin,
Yes, sir.
just like to go through your history again first.
Sure, sir.
So by your history, what do you think you're dealing with? You've got a mass in the epigastrium and pain. What
Yes,
do
sir.
you think it could be?
Sir, with the sudden onset of symptoms and with such a short range of time, I was thinking more in terms of a malignancy. And since it was in the epigastrium, I was sort of thinking more in terms of a gastric malignancy initially. He's also had a history of exposure to smoking and alcohol. However, there are no symptoms suggestive of a gastric outlet obstruction.
So what are the clinical features? What do the patients generally complain of in a case of gastric malignancy?
If it were a gastric malignancy, a patient would have complaints of anorexia, loss of weight, loss of appetite. He would have hematemesis. He will also complain of vomiting after taking feeds. He may also complain of abdominal distension after taking orals, which may not occur immediately, but after a period of time. Patient may also complain of melena.
So can there be just pain, weight loss, and silent, no symptoms? Can stomach carcinoma present as silent?
Sir, it may be present, sir, if there is not a significant obstruction at the level of the pylorus, and if the tumor was located more proximally.
Silent means, suppose, what kind of tumors would present without melena, or bleeding and obstruction?
That's that which would not involve the mucosal surface, sir, I believe.
Okay, and anything else?
Sir, in terms of gastric or in terms of any other tumor, sir?
Gastric, was gastric.
Perhaps linitis plastica also, sir.
Linitis plastica, okay, but they are generally small, very small, and they present with vomiting after taking small meals.
I would like a differential of gastric lymphoma,
Right.
sir, in this case.
Right. So it can be a lymphoma or anything which is not involving the meals. Let's go to your first slide, please.
Dr. Rubin, are you excluding pancreatic pathology at this point?
Sir, I would like to include pancreatic pathology in my differentials, since the patient is also a chronic alcoholic. However, the patient has not had previous attacks of pancreatitis in the past, previous hospitalization for the same. But he was a chronic alcoholic.
That makes you rule out pancreatitis.
Yes, sir. Sir,
That's
I would
because there is no history of previous admission.
I would like, sir, I have elicited history and he does not have any history suggestive of a previous history of pancreatitis, sir.
No, is it necessary to have a previous history of pancreatitis to think it is a pancreatic tumor?
Not necessarily, sir.
So what are the
Doctor,
other pancreatic causes which you can think of other than malignancy?
I would think of a pancreatic pseudocyst if he had had previous histories of recurrent pancreatitis, sir.
Can pseudocysts present without a history of pancreatitis?
Pardon, sir. Can you please repeat the question, sir?
Can a pseudocyst present without a previous history of pancreatitis?
Yes, sir. It is possible.
Like what?
Pardon, sir. Can you please?
Okay. What would the patient give a patient of pseudopancreatitis, which is not due to chronic pancreatitis, give you a history of?
Sir, he may not necessarily be an alcoholic, but he may have a sudden occurrence of a swelling in the epigastrium, sir.
Anything to do with trauma?
Abdominal trauma does predispose, sir. There is a predisposition. And in this case, there was no
Predisposition. How does it predispose?
there. That
It
is
can't cause.
that is
How does it predispose?
sir. The pancreatic parenchyma would get damaged, and it would result in leaching out of the exocrine enzymes.
So it's not predisposition; it's the cause.
Cause, yes, sir.
Dr.
Can you go to the
Ruben,
slide?
Dr.
Madam?
Ruben, I have a small question.
Yes, ma'am.
So when you say that you do not have history suggestive of pancreatitis, what history you want to elicit, which would suggest whether it's a chronic or an acute pancreatitis? Because this is a case of short history, 1 month duration, and lump is also for 1 month. So what history would you elicit to rule out either acute or chronic pancreatitis?
Ma'am, if my patient had presented with recurrent episodes of vomiting with acute abdomen, more so an epigastric pain,
you have pain in the epigastrium, you have
however,
recurrent pain history,
yes,
and you have history of alcohol intake.
ma'am, however, in
So-
this case, the pain was dull aching in nature and not the kind of
Yes.
severe pain that you get in terms of pancreatitis, and in this case also the pain wasn't necessarily radiating to the back as we see in
Yeah.
pancreatitis.
Yes.
And in the former, you also get relief in pain while you lean forwards. That is the Mohammedan prayer sign. So this is not here in this. So clinically, I was able to rule out that way.
Ruben,
Right.
you have put there is no referred pain.
Yes, sir.
Where do you get the referred pain from stomach or the epigastric region?
Sir, it would be more of a radiating pain, sir, rather than a referred pain,
Please
sir.
must very carefully put the word. It is a radiation pain you are expecting, not
Yes, sir.
just.
Yes,
And
sir.
you have put it as an insidious onset. Why do you want to put it as an insidious onset?
Sir,
What do you
the
mean by
patient-
insidious onset?
Sir, insidious means it would have happened in the past, but the patient is not able to pinpoint exactly in the timeline when it happened. So when the patient actually noticed he had the lump, he was not able to tell when it happened. That is why I put the phrase insidious, sir.
Not always. All the swellings need to put as an insidious.
Okay, sir.
The exact meaning of insidious is different. It is with a harmful intent. A swelling which has been started with a harmful intent. Patient apparently been deceived. He thinks it is a normal, it is there. Suddenly, when he see it is becoming complicated, then you are putting it as an insidious onset. But here,
Okay,
already
sir.
there is a scar, big scar is there. Patient has a swelling is there.
Yes, sir.
Patient could have been noticed. He is abdomen. He is noticing everything. Was saying just 1 month back he has seen such a big mass he has seen,
Yes, sir.
and the pain is only in the epigastrium.
Yes, sir. Restricted to the epigastrium, sir.
You have put as early satiety
Yes, sir.
because the
So
picture.
why do not think?
The picture what you are seeing, you have shown the picture, no? That the mass was looking little down, not in the gastric region, much
Yes,
more.
sir.
Okay.
I'll show you in detail, sir. The
Okay,
picture is
okay.
slightly, yes, sir. May I
What do you mean by that early satiety?
Sir, a feeling of fullness, sir, despite having appetite, a feeling of fullness, sir.
What do you think the reason could be?
Sir, probably the inability of the stomach to distend completely, which results in the
That
early.
is, stomach lesion is there in the stomach, inside the stomach, or the wall.
Yes, sir.
So what is the reason why it is not able to distend?
Sir, probably dysplastic changes in the cells, sir, preventing the stretching of the stomach.
Stretching stomach.
As in the distensibility, I don't know the right word to put it, sir. But yeah.
Is it the only reason?
Sir, also the capacity of the stomach will be impaired if there is a tumor that is.
We agreed. Other than the tumor inside the stomach or the carcinoma stomach where the muscle is involved, so contractility is lost. Other than that, do you have any reason?
Tumor necrosis factor alpha, sir.
No, that is not going to do the early satiety. That is loss of appetite. It's going to cause the loss of appetite.
Yes, sir.
Other than the tumor arising from the stomach itself, inside the stomach or the, if you have any other reason? Can a patient with a pseudopancreatic cyst have early satiety?
Yes, sir. They present also with early satiety because of compressive effect.
A compressive effect, not only from arising from the wall,
Yes,
from the external compression. Any structure which is there is an external compression. And
Okay.
you asking for a sweating, loss of fever. Is it for a lymphoma?
Yes, sir. I would like to rule out a lymphoma.
Anything specific for a gastric lymphoma?
Sir, I would like to rule out an evening rise of temperature in this patient, sir.
How do
And
you make what is the specific characteristic features of a gastric lymphoma? What is Dawson criteria?
Dawson criteria.
Gastric lymphoma is entirely different from
Yes,
other
sir.
NHL you are talking about.
Yes, sir. Yes, sir. I'm not too sure about the.
It should be confined to the stomach. No mediastinal nodes should be there. No liver spleen involvement. TCDC should be normal.
Okay, sir.
So then only you should be able to put that as a lymphoma. So thinking of lymphoma, you must put as a very extreme cause, not as a very commonly routine. We have put only 3-4 reasons, and you don't
Yes,
bring
sir.
a lymphoma as the cause there. So,
Okay, sir. May I proceed, sir?
Yeah, I have a small question for you, Dr. Ruben.
Yes, sir. Yes, sir.
Here, laparotomy is short duration. He has noticed it, dull aching pain. Noticed a lump abdomen. Why is it not an incisional hernia?
yeah,
Sir,
that is good.
Because, sir, that would be more on the examination side. But yeah, the patient.
So why are you not thinking of it?
Sir, because one thing is that patient has sustainedly had the mass irrespective of carrying heavy weights or exerting strain. So if it were an incisional hernia, that is, if it were a reducible incisional hernia, I would suspect that the mass would increase in size if the patient.
Yeah, now it has become irreducible. That's why he's having the pain.
Sir, it may be a possibility, sir. I cannot rule out just on history, sir.
Yeah, so you can have a thought about it also, isn't it? You have not yet gone to examination, right?
Yes, sir.
You're thinking of stomach only, but
Yes,
there is a history of a laparotomy.
Yes, sir.
Yeah. Please carry on.
Ruben, do you think that the laparotomy is associated with this problem?
Sir,
Any association between the laparotomy and this problem?
sir, one thought that I had was, what if he had a peptic ulcer disease, a perforated peptic ulcer or of sorts previously, because it was a large midline laparotomy, not a lower midline.
Right.
So I'm thinking that maybe given his alcoholic history, I was thinking probably he had some peptic ulcer, perforated peptic ulcer, which resulted, in going forward with an emergency laparotomy, and maybe now he has a gastric stomach associated malignancy. So that was just one thought that I had.
Okay. Now, specifically, you said somewhere that you asked for the yellow discoloration of the skin,
Yes, sir.
sclera, and mucous membrane. No?
Yes, sir.
You do not want to ask anything else for the yellow discoloration?
Sir, I would like to know whether he always had a yellow discoloration or an onset of yellowish discoloration, sir.
No,
As
so
in-
you're only interested in the sclera,
No,
the
sir.
skin and the mucous membrane, isn't?
Sir, I would also like to know if patient had pruritus and if he had.
No, yellowish discoloration, I'm asking.
Yes, sir.
What is the first presentation of a patient who has got the jaundice? Does he complain of yellowish of the sclera, or does he say that his urine is getting yellow now?
Sir, he says he's passing high colored urine.
So did you mention somewhere?
Yes, sir. I mentioned a negative history of not passing high colored urine and pale colored stool, sir.
Okay. Now tell the patient has got a jaundice,
Yes,
but
sir.
his urine is not high colored.
Okay, sir.
Can it happen?
Possible, sir, if it's more of a subclinical jaundice could be
No,
there.
patient has got a bilirubin of 6 milligrams.
Okay, sir.
But he said my urine is okay.
Probably hepatic.
What is acholuric jaundice?
Pardon, sir?
Acholuric jaundice.
Sir, I don't recall the definition, sir, but I have heard the terminology.
Tell
sir.
what are the various types of the jaundice? Main
Sir,
3 types of the jaundice, tell that.
Pre-hepatic,
Yes.
that is hepatocellular, hepatic, and post-hepatic.
Right. So what will happen in the pre-hepatic?
In pre-hepatic, there should be a antecedent cause for the jaundice, which could be, for example, a lysis. I mean, hemolysis.
So
Or
if hemolytic jaundice is there,
yes,
what
sir,
will happen to the urine?
which results in the degradation products being released, and urine can be high colored, sir, because of conversion of biliverdin and bilirubin. And
What
then,
makes the urine yellow?
sir, there is the oxygenation of the urochrome compound and bilirubin, sir.
Which bilirubin?
Sir, there is delta bilirubin, which is carried by the albumin, which is then undergoes conjugation in 2 stages, and then that is released.
So is it a conjugated bilirubin or an unconjugated bilirubin?
It should be the conjugated bilirubin, sir.
Okay, so if it is a conjugated bilirubin is there,
Yes, sir.
and what happens in the hemolytic jaundice?
Hemolysis will result in increased breakdown, sir. So
which bilirubin will be there in the urine in case of the hemolytic jaundice?
unconjugated should be there, sir.
So it is unconjugated bilirubin. No?
Okay.
So that is why the urine is not yellow.
It's not yellow. Got it, sir.
Okay.
Yes, sir.
Did you get it?
Yes, sir. Understood, sir.
All right.
Okay, sir.
Okay, now tell the sclera is white, but the urine is yellow.
Sclera is white, but the urine is yellow. Something like sir, post-hepatic.
What is the commonest cause of yellow colored urine, especially in the relatively elderly person?
Urinary tract infection or
Yellow color.
one thing is supplements, sir. Everyone takes B12 supplements and it turns yellow.
Supplement, yeah, that is the commonest cause for that, no?
Yes, sir.
If the patient is taking the B complex, that
Yes.
is the commonest cause for the yellow colored urine.
Yes, sir.
Okay, go ahead. Yeah.
Okay, sir.
Why conjugated bilirubin is causing yellow and unconjugated is not causing yellow color?
Sir, conjugate only binds to the, I mean, it has affinity to the elastin that is present in the sclera.
We are talking about the urine.
Sir, oxygenation of that compound only results in the yellow color, sir.
No. It's soluble in water.
Yes, sir. It is soluble in water. Yes, sir. It is soluble in water. Yes, sir.
You need to keep an open mind at this point, okay?
Yes, sir.
Besides pancreatic pathology, we also should include a liver pathology here, including
Okay.
a hepatocellular
Not
carcinoma.
that,
Okay, that
but,
should also be there.
Okay.
You are more focused to one side. You are not keeping your history wide open and not going to point out. You are just in the history without even asking some question, you are ruling out something.
Okay,
So
sir.
it's not good. You always keep it open, think of all the possibilities, then you can go ahead.
Okay, sir.
Go to the examination.
Okay, sir. On examination, after obtaining verbal consent from the patient, I examined the patient in a well-lit room and provided adequate privacy. The patient is oriented to time, place, and person. He's fairly hydrated, not febrile. He's poorly built and nourished, with a BMI of 19.5, which falls under the normal range, and an ECOG class of 1. There's no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. He's vitally stable with a pulse rate of 84 per minute, a blood pressure of 130/80 millimeters of mercury, respiratory rate of 16 cycles per minute, and a saturation of 98% in room air. Apologies for the differently oriented picture, but there seems to be a slight deviation. And I mean, he's not properly supine. He's not properly supine, so I was not able to mark it properly. But this just marks the borders of the margins of the lesion, the mass. The xiphisternum is right here, and the lesion seems to, the mass seems to extend from the xiphisternum 4 centimeters below the umbilicus. The midclavicular line goes along these ends.
You are going to the inspection now.
Yes, sir.
What is the
Yes, sir.
your inspection means you have to present in the proper way of inspection.
Yes, sir. Yes, sir.
In the general examination, you have put there is no radial delay and radiofemoral delay.
Yes, sir.
So why do you want to examine this here?
Sir, the only thing is that he had coronary artery disease, and I just
Only look for radial delay.
I would measure both the, with both my hands, I would measure the radial pulse of each upper limb, sir.
So what do you expect? And if
I mean,
there is radiofemoral delay, right
it was
side
not-
or left side, which side will go for delay?
Sir, there was no discordant change as such. There was no change, sir. There was no difference as such, sir, unless he has an aortic stenosis of sorts.
Aortic stenosis.
A post, sir,
So you have only in the clinic examination, we are going to give only 40 minutes for you.
yes, sir.
So what you couldn't do, radiofemoral delay, have you examined? Have you done?
Yes, yes, sir. Radiofemoral delay I checked, sir, and there was no delay.
So please, unnecessary tests you don't do. That means
Okay,
that you are not prioritizing your focus examination where you are going to do.
Okay, sir.
This is not, we are not expecting a coarctation of aorta, and it is nothing to do with your diagnosis or management. That will come in the later part.
Okay, sir.
General examination, which is needed for that. You have put us a poorly built. What made you to think he is poorly built? What is
Sir,
built?
Built is the comparison of the patient versus a normal adult for that age, sir.
No. What is the meaning of build of a patient?
His overall body structure, I believe. I don't know the specific definition, sir.
Skeletal stature or the skeleton of the patient.
The skeleton.
Yes, sir.
So if he is 6 feet high, 6 feet height, he has a good build.
Okay, sir.
And the nutrition is the soft tissue.
Yes, sir.
Just because he has come to the hospital, don't make him so poorly built.
Okay, sir.
So that means you have to examine the general examination part also. It is very importantly, you have to look into that.
Okay, sir.
Go into the proper inspection.
Okay, sir. In
If
examination,
you get the radial delay in a case of coarctation of aorta
yes, sir.
and radiofemoral delay,
Sir, I do not remember the cause, sir. I'm sorry.
no, radiofemoral delay is because of the coarctation of aorta. No?
Okay.
Coarctation. Normally, the
Radial
coarctation happens
because
before
of,
the
Pardon, sir.
radial delay because of
If there is a subclavian steel,
yes, subclavian artery. No?
yes, sir.
You know any generalized disease where you can get all these abnormalities? What is the name of that disease?
Uh, is it Marfan syndrome?
Have you heard of the Takayasu's?
Takayasu arthritis. Yes, sir. Endarthritis, rather.
I think Takayasu's arthritis. Sometimes even the tubercular arthritis.
Okay, sir.
Okay, that can you get all these type of problems. Okay, go ahead.
So you understand, Dr. Ruben?
Yes, sir.
So unnecessary. Suddenly your exam can go this way, that way.
Okay, sir.
That's
Got
the
it.
whole focus here, right?
Yes,
Carry
sir. Examining abdomen. All quadrants move with respiration. The umbilicus is in the midline and inverted. Skin over the mass shows a midline laparotomy scar, which has healed with secondary intention. There is no visible gastric peristalsis and no visible intestinal, no dilated veins and sinuses. A 17 cross 18 centimeter single well-defined mass is noted involving the epigastrium, umbilical region, left and right hypochondrium. This extends from the xiphisternum superiorly to 4 centimeter below the umbilicus and laterally, bilaterally abutting the midclavicular line. This mass moves with respiration. On head racing test, the mass regresses partially. Bilateral hernial orifices appear free, bilateral flanks appear free, bilateral renal angles, there is no fullness noted. External genitalia appears normal, and there is no left supraclavicular fossa fullness. There is a mistake in my diagram, sir. I was not able to expand this circle without affecting here, sir. I should have occupied bilateral hypochondriac, sir. On palpation, the inspectory findings for size and shape of the mass is confirmed. There is no tenderness, there is no guarding and rigidity. I confirm the findings that I found before, sir. 17 cross 18 centimeters, single well-defined mass involving the epigastrium, umbilical region, left and right hypochondrium, sir. Margins were well-defined, but I was not able to palpate the upper border. The mass itself is non-tender, firm in consistency. The surface is smooth and it is slightly mobile side to side, sir, in the transverse axis. And this mass moves with respiration. I was unable to insinuate my fingers between the mass and both the subcostal margins. The plane of the swelling is intraperitoneal. It is non-pulsatile. Bilateral hernial orifices, flanks, and renal angles are normal. The external genitalia is normal, and there is no palpable left supraclavicular node. On percussion, the liver span dullness was noted in the right fifth intercostal space and superiorly, and the liver span was 12 centimeter. The dullness was continuous with liver. However, tone of dullness over the mass was more. There was no evidence of free fluid. In auscultation, the bowel sounds were normal. There was no arterial bruit or venous hum. No succussion splash was noted, and ausculto percussion was negative in this case. I did a digital rectal examination. It was unremarkable, and there was no Bloomer's shelf. In systemic examination, I had normal heart sounds, no murmurs. Bilateral air entry was present, and there were no deficits noted in the central nervous system. I would like to summarize my case. A 55-year-old male who was a farmer with a known case of coronary artery disease and systemic hypertension, post-emergency laparotomy with abdominal pain, upper abdomen mass, early satiety, loss of appetite and loss of weight for a period of 1 month, who was a previous smoker and who consumed alcohol for 10 years with stable vitals and a mass which is 17 cross 18 centimeter occupying epigastrium, left hypochondrium, umbilical region, right hypochondrium, which is firm, non-tender, mobile side to side, intraperitoneal, with no VGP, no palpable left supraclavicular node, and no Bloomer's shelf. I would like to place my differentials before you. First being a gastrointestinal stromal tumor arising from the stomach. The second being pseudocyst of pancreas, and the third being HCC involving the left lobe of liver.
You've not kept a gastric lymphoma in your differential diagnosis?
No, ma'am. It can be a probable yes, ma'am. I should have added, ma'am.
Pseudocyst of pancreas has got side to side mobility or moves with respiration?
No, ma'am. It doesn't.
So why don't you keep a diagnosis of pancreatic tumor?
I was trying to fit in differentials that would be isolated to a large epigastric mass. And
Which pancreatic tumors move with respiration a bit?
involving the tail, sir.
Yeah.
Retroperitoneal structure, no?
Sir, pardon, sir.
It is a retroperitoneal.
Yes, sir. And large retroperitoneal tumors may present as a epigastric mass as well.
Mobility, I'm asking. You said mobile tumor.
Mobile, sir. It is not retroperitoneal, sir. It is intraperitoneal.
See, the pancreas is a retroperitoneal structure, right?
Yes, sir.
The tail of the pancreas lies in the landoidal ligament near the splenic hilum.
Right?
Yes,
sir. Yes,
yes.
sir.
So some amount of mobility is expected, and those tumors can become quite large also.
Yes, sir.
Instead of a pseudocyst of the pancreas, which is a purely retroperitoneal structure and which is inflammatory in nature,
Yes,
which
sir.
doesn't move with the respiration,
Yes,
but
sir.
neither does it move from side to side. Here, what you consider a pancreatic tail tumor. Okay.
Yeah, and especially when the pancreatic tail tumors become large, then you can get that side to side mobility.
Okay, ma'am.
Given which groups of lymph nodes did you palpate for?
Sir, I checked for umbilical nodules and I checked for supraclavicular group of lymph nodes, sir.
What did you find?
There was nothing significant, sir.
Supraclavicular lymph node on the right side or the left side?
I checked bilaterally.
Bilaterally.
Yes, sir.
Okay. Which side is more important?
Left side, sir, because of its relation to the thoracic duct.
Thoracic duct. Okay.
Sure.
So, what is that lymph node called? The left supraclavicular lymph node.
Furcose node, and it's called trocheus sign, sir.
Trocheus sign.
Yes, sir.
What is Virchow's triad?
Virchow's triad is related to this one, sir. Hypercoagulability, stasis, and endothelial damage. That is completely different. Yes, sir.
So, trocheus sign, can you get trocheus sign also in this
No,
patient?
sir.
If he has trocheus sign, can he get trocheus sign here?
Trocheus sign, trocheus sign regarding the there may be if it is a gastric tumor, sir.
Can the pancreatic tumor produce a trocheus sign? What is trocheus sign?
Sir, it is
You get in the legs.
yes, sir.
So there are two trocheus signs involved here. So what are the two trocheus signs? Which one you might get here?
Sir, troisier is here.
No, trocheus we got that. Trocheus we got. We're talking about trocheus sign. There are two of them involved here.
One
Which
is
one?
hypocalcemic tetany troceo, and one is
What is that problem? It's a
thrombophlebitis,
paraneoplastic
sir.
situation,
Pardon?
right?
Yes, sir.
Pancreatic tumors
Yes, sir.
produce some paraneoplastic
Yes,
conditions.
so there
right?
may be a hypocalcemia associated with it.
No,
Sir.
not that. The trocheus sign. What is that?
With superficial thrombophlebitis, sir.
One important word you should add. Migrating thrombophlebitis.
Thrombophlebitis. Okay, sir.
Can you go to the inspection slide, first slide?
Yes, sir.
The one thing which you said in the palpation, you are saying upper border is not palpable.
Yes, sir.
But inspection and palpation, the same size you are mentioning, 16 into 7 centimeter size.
Yes, sir.
You are sure? And in the picture also, you are showing up to a ciphisternum, it is going, but the picture, the mass on inspection, we are not seeing it is going up to the ciphisternum.
Yes, sir. Sir, in the picture, it seems that it is well isolated. However,
Inspection finding on a picture, where is the ciphisternum, and is it going up to the ciphisternum?
yes, sir, it's going up to the ciphisternum, sir.
You have put a mark. You have marked a mark. It is much below the ciphisternum.
Yes.
Palpation, you would have been seen that. I mean, felt that. We are not able to see. But on the inspection and palpation cannot have the same size as per your description.
Yes, sir. I should have put like about 2-3 centimeters below the ciphisternum.
Don't try to change the findings. Whatever you see, inspection, this is what I am seeing. Palpation, lower upper border, I am able to go a little more above. Then you can put in your own size.
Okay,
Second, where is the umbilicus? Is it in the midline?
Sir, in this picture, it appears a bit distorted because of the angle in which I took the photo, sir, but it was in the midline, sir.
The angle you are showing. This is what we are seeing in the examination. No angle you are showing. See the pubic, the distance between pubic symphysis and umbilicus and ciphisternum to umbilicus.
Yes, sir.
It is a huge difference. What is Tenniel sign?
Sir, pardon, sir. Sir, can you please repeat, sir?
Tenniel sign. TANOEOL.
Sir, I do not know, sir.
Upper abdominal mass will push the umbilicus down, or the lower abdominal mass will push the umbilicus up.
Yes, sir.
And in your examination, you have never mentioned about the scar. Is it any defect in the scar? You have not checked for a cough impulse.
There was no scar dehiscence, sir, and there was no cough impulse along the scar, sir.
It is fine. It cannot be, need not be. But
yes,
this is the one solely with the extending, the scar is there, the present there, and the possibility of a hernia, or at least in an examination, the scar is healthy, no defect. You are able to see whether the swelling is reducible or not. All this has to be mentioned.
Okay, sir.
That is one of the very important thing.
You didn't describe palpation of the external genitalia.
Sir, I've mentioned external genitalia as normal in my inspection.
Okay.
Patient, sir.
Can a small lump of the testis be associated with a large epigastric lump?
Sir, I would definitely check the scrotum in case of a male patient because I would like to rule out a testicular tumor causing a large para-aortic node.
Okay. Where are the para-aortic nodes usually located? In which part of the quadrant of the abdomen?
Sir,
hypogastrium, epigastrium, or umbilical region? Where are you likely to find?
Sir, hypogastrium, sir.
No, epigastrium actually.
Okay,
where the aorta is finishing, eh? It is just below the renal vessels, isn't it?
Yes, sir. Yes, sir.
So, see, whenever you have a scar, this is for your further clinical presentation. Whenever you have a scar, you have to examine that scar. You have to check for cough impulse. You have to measure the length of the scar. You have to say that. And you already said that it is healed with secondary intention, right?
Yes, sir.
What does that mean? That means the scar has a potential for a hernia formation.
Yes, sir.
If a scar is healing by secondary intention, a wound is healing by secondary intention, producing a scar, that scar needs attention.
Yes, sir.
You're talking about things without leaving the scar aside. So you're somewhat down the line, you're biased about it. So you know as if that is not there. You have to examine to know whether it is there or not, whether any problem is there in the scar or not. Isn't it?
Yes. Noted, sir.
Very important now. What is auscultar percussion negative means?
Sir, in this case, I did not find that the stomach was distended, sir. When I performed the auscultar percussion.
Is it a sign to say that it is positive or negative? It is only to measure how much the stomach is distended. And how did you do auscultar percussion when there is a mass is there?
Sir, towards the left upper quadrant, it was very difficult to perceive the borders of the stomach, sir. However, as I went down, I could perceive the borders of the stomach properly, sir. In the upper aspect towards the fundus, I was not able to perceive the borders of the stomach.
Nobody looks for a fundus border.
A greater
auscultar percussion.
Greater curvature only has to be. Yes, sir.
If you are not done, if you are not expecting the stomach be distended. You are not expecting it is a GO obstruction.
Yes, sir.
If you don't put as auscultar percussion as a negative,
Okay,
if at
sir.
all there, the border in the surface of the patient, the margin should have been marked.
Okay, sir.
See whether it is a distended or normal stomach.
Okay, sir.
So you also mentioned about succussion splash.
Yes, sir.
Yeah. So what is the important thing you should mention about the succussion splash before doing it?
Patient has to first consume liquid, and I would allow the patient to I would examine the patient after 3 hours, and then place the bell of my stethoscope at the epigastrium
So that means there has to be a waiting period of 3 to 4 hours, right?
to permit gastric.
So whenever you do a succussion splash, you have to ensure that.
Yes,
And
sir.
that has to be said in the examination before
Okay.
saying the succussion splash is positive or negative. So you have to say that there's a waiting period and the succussion splash was done. It was found to be not present.
Not present. Yes, sir.
You have mentioned in
It's not a
margin
part
as
of auscultation.
same
It should
thing.
come much earlier. That's the first thing you
Yeah.
are going to do before even seeing for the VGP.
Okay, sir.
So you also mentioned in your examination findings that it is going underneath the subcostal margin. What is the subcostal margin? And what is the costal margin?
It should be costal margin, sir.
Yes,
Because
there is nothing
it's
called a subcostal margin.
Sir,
It's a
okay.
costal margin.
The
Now
costal
in
margin.
in the picture which is right in front of us, so on the side where the patient is lying down supine,
Yes,
you've
sir.
taken a picture from the side. Can you
Yes.
trace the costal margin there?
Just a second, sir.
Yeah, you can see it.
Yes, sir.
Yes. And that upper margin of the tumor doesn't go inside the costal margin.
Yes, sir.
So whatever you are presenting, you should corroborate what you are saying and what the picture you're producing. When this thing happens, there's strong suspicion, isn't it?
Yes, sir.
Yeah. So what it is actually, is it going underneath or is it not going underneath? Now you tell us.
While palpating, sir, I was definitely not able to insinuate my fingers underneath, sir. I could feel my fingers hitching at the junction. I could not go underneath at all. I could not define it at all, sir.
Okay.
Then how could you tell the liver span in this patient?
Sir, that was on the right side, sir, not on the left side, sir.
On
You
the
said
right
bilateral.
side, it is going right up to that area, isn't it?
Yes, sir.
This
But I
mass
could,
is going right up to the mid-clavicular line there.
yes, sir. But I
You're
could.
telling the liver span.
Yes, sir. It may be an
It will
overlap.
be
of, sir.
continuous with the liver span. If you percuss there, it will be continuous with that. So you
Right.
cannot tell the liver span there.
Right, sir.
And why in this patient you have not kept a possibility of the retroperitoneal tumor? A large tumor which is there in the central part of the abdomen. Why not a retroperitoneal tumor?
You are not even done any test to see whether it is intraperitoneal or retroperitoneal, but you are mentioning as intraperitoneal.
Sir,
You have done only a head tracing test.
Sir, the knee elbow test can be done, sir. But the patient is having
No need to
lower-
knee elbow position. No need for knee elbow position.
Okay,
Even
sir.
any other position.
What other position you should examine the patient to decide that?
Sir, I could put the patient in left lateral decubitus and see whether it falls.
So what are you trying to
Fine.
find out in the left lateral position?
If it
You have
falls,
not done that test.
I have
What
not.
is that thing? What is that thing on palpation you get in a retroperitoneal tumor situated in this side part of the abdomen?
It should,
Or inspection also.
sir. It should not become prominent, sir. If it's a
The
retroperitoneal.
swelling is situated in front of the aorta if it is retroperitoneal, isn't it?
Yes, sir.
So what should you get?
I should get an expanse. I should be able to.
You should
feel
guess a-
transmitted pulsation, sir.
Pulsation. You'll get a pulsation.
Yes, sir.
Perfect. Now, when you turn the patient on the left lateral position, what happens to that pulsation? If it is a retroperitoneal tumor,
If it's retroperitoneal, then the pulsation should not persist, sir, because
it's not arising out the aorta, right?
sir. So
That's what you are trying to differentiate,
Yes, sir. Yes, sir.
isn't it?
Yes, sir.
So, did you mention that about the pulsatility of this tumor is crossing the midline centrally situated?
Sir, I have just mentioned that the tumor is, I mean, the mass is not pulsatile, sir.
In such a situation where you cannot assess the liver span because it is getting continuous with the liver dullness,
Yes, sir.
how do you assess the liver span?
It is difficult to assess, sir.
No, it is not difficult. You are assessing the liver span in the midclavicular line.
Yes, sir.
You have to move
Yeah.
to some other site.
And more towards the anterior axillary.
What is more towards? There is a line there. What is that line?
There's an anterior axillary line
That is very close to the midclavicular.
or a mid axillary line.
Is it there or not? You're asking me.
Sir, it is there, sir.
Yes. So there is a mid-axillary line.
Yes,
So
sir.
you can go to the mid-axillary line and assess for the liver span.
Yes, sir.
What is the normal liver span in the mid-axillary line?
Sir, I do not know, sir.
Is it more than the midclavicular or less than the midclavicular?
When you are bringing in a midclavicular line and when you are measuring on the mid-axillary line, is there is a difference or the same?
Sir, I think mid axillary should be more than the mid clavicular.
So liver is
But
more
wait.
posteriorly or more anteriorly?
Sir, pardon, sir.
Liver mass of the liver is more anterior or more posterior?
More posteriorly, sir.
More posteriorly. Hey man, when you do a cholecystectomy, you have to pull up the liver from above.
Yes, sir.
You have to pull it above from anteriorly.
Yes, sir. Anteriorly.
What is the normal mid-axillary span of the liver?
I don't know, sir.
What is normal mid-clavicular span of the liver?
12 to 14, sir.
Huh? क्या बोल रहे?
So you must go back and check normal patient liver on both sides and ask a palpate, percuss and find out.
Okay, sir. I'll do it. Yes, sir. Sir, I have a discussion part ahead of this, sir, for which I had proceeded with my patient. May I continue, sir?
Yeah, go ahead, go ahead.
For this patient, I would like to confirm my diagnosis. I would like to stage my disease and finally do tests for the fitness for surgery.
What do you mean by stage of the disease?
Sir, to stage the disease based on...
How do you know what disease you're staging? Or what is that actually? You have made 3 diagnoses,
yes,
isn't
sir.
it? Go back to your diagnosis, differential.
Yes, sir.
Yeah.
And at this point, what are you staging?
Ma'am, initially, I would like to first find a histopathological diagnosis.
No. Let's try to understand. What is your first diagnosis?
Gastrointestinal stromal tumor, sir.
What staging you want to do? Why are you bringing the stage? First, you have to confirm your diagnosis.
Yes, sir.
Isn't it? You're making yourself very vulnerable.
Okay.
You have made a first diagnosis as GIST,
Okay, sir.
right? Second diagnosis as pseudocyst of the pancreas. So both are non-malignant conditions, right? The simple GIST which you're talking of.
No.
You're not talking of a malignant GIST here, isn't it?
Yes.
Okay. And the third one, you have put a hepatocellular carcinoma, which is malignant. So what is your approach here? So your predominant assessment of the tumor is benign. Why unnecessarily going for staging? Only when you find out during investigation that it is a malignant tumor or a malignant mass, then you look for staging.
Okay, sir.
Right? First is your confirmation, investigation to confirm my diagnosis.
Okay,
So
sir.
start with those.
Okay, sir.
And if you think it is a benign one, then why did you mention the ECOG here? If you think it is a benign one,
Yes, sir.
why you are putting the ECOG?
Either way, you are caught, Ruben.
Yes, sir. I was more
So
thinking of
if you want to be a little more smart in that, then it
sir,
will be better to put the Karnofsky there.
Karnofsky's performance scale. Yes, sir.
ECOG is for the cancer only, jo hai na?
Okay, sir.
It is the Eastern Cancer Cooperative one, hai na? It is for that only, oncology group.
Yes, sir.
If you want to, you can put the Karnofsky.
Okay, sir.
All right. Okay, go ahead.
For this patient, we proceeded with an OGD scope.
And then the third, you said fitness for the surgery.
Yes,
Do
sir.
you think the surgery is the only treatment for that if it comes out to be like a lymphoma?
No, sir. He would need the regular blood investigations as such.
Rather than saying surgery, fitness for the treatment.
Okay, sir.
Whether it is the chemotherapy or the radiotherapy or the surgery, whatever it is.
Okay, sir.
Okay, so rather than writing surgery, fitness for the treatment.
Got it, sir.
Okay.
We performed an OGD scopy for the patient. A large extraneous impression in the greater curvature of stomach was found. And with the central ulceration noted in one of the lesions in the OGD report that we received, we saw
Sorry to interrupt, Dr. Ruben.
Yes, sir.
So is there anything in your history and examination to suggest that it has got a luminal component?
No, sir.
So what is the first investigation here?
Ideally, I should have done an X-ray abdomen erect followed by an ultrasound.
Ultrasonogram of the abdomen, right? The standard basic investigation available everywhere, point of care, right? So the first investigation is to know, you are not very sure what is the organ of origin of this tumor or this mass, this lump.
Yes, sir.
So first you have to find out which organ it is coming from. Then you have to find out whether it is benign or malignant, right?
Yes, sir.
So what is your ultrasound finding here? Have you done it?
Sir, we hadn't done an ultrasound, sir. He already, since his mass was vaguely in the epigastrium and he had a significant loss of weight and appetite.
He has loss of weight and loss of appetite, this, that, everything. Does he have in hematemesis melina?
No, sir. He didn't have
No,
any.
he doesn't have, right? Doesn't have a nausea, vomiting also.
No, sir.
No. So he has it is expected that you are talking of a tumor which is outside the stomach, maybe associated with it, but not luminal.
Yes, sir.
So here the first diagnosis, first investigation is a ultrasound. It's a screening investigation. It's an extension of clinical acumen.
Yes, sir.
Because you are one of the differential diagnosis is pancreatitis, left liver carcinoma. Then how can you directly go to the OGD scopy? Even if you think as your first diagnosis of the GIST, OGD scopy is not a diagnosis.
Yes,
The
sir.
ultrasound is a basic investigation which you should have done.
Yes, sir.
Okay.
Sir, so in this case, the report that we received was like in the impression that they had drawn, there was like multiple lobulations, which caused a extraneous impression over the greater curvature. And one among those lobulations had a central ulceration. From that ulceration, a biopsy was taken, which showed no evidence of malignancy. We had done
If there is no ulcer, then what biopsy you would have taken?
a well biopsy should have been taken. Or a biopsy from 10 representative sites should have been taken. At least six or 10.
Was there any mucosal lesion?
Yes, sir. Actually,
No, the question is very simple.
question
There
is-
is no ulceration.
sir, there was an
No
ulcer-
mucosal lesion.
one
What you
ulceration,
do?
sir.
No, suppose you are seeing no ulcer. What biopsy? You are seeing lobulation, you are seeing all that except an ulceration.
A well,
What is well biopsy?
well biopsy, sir, and
Okay.
excreting biopsy.
So in that area, you should go for a well biopsy.
Sir, parallelly, we had done a CCT abdomen and pelvis, sir, with oral and IV contrast. In this case, we found a well-defined large lobulated and lesion with internal areas. It is about 12 cross 18 cross 18 centimeter. This was noted in the left mesochoric compartment of the peritoneal, and the extent was from thoracic 11 to lumbar third vertebral level, sir. This was exerting a mass effect and displacing the stomach posteriorly as per the CCT, and small bowel loops were displaced inferiorly, and this lesion abuts the inferior surface of the left lobe of the liver and the anterior abdominal wall. We also found lesions in the liver, sir. 2 lesions, one in segment 8 and calcific foci in the segment 7 of the liver, sir.
This CT report is not telling anywhere the site of origin of whatever lesion this is.
Yes, ma'am. Our
Nowhere
impression.
it is saying from where it is arriving.
Yes, ma'am. This was the final report that we had received. It was not even the provisional, it was the final report that we received. We were thinking more of a gastric origin since something was pressing on the stomach, but the ultimate thing that we proceeded with was interventional radiology opinion and proceeded with the CT guided biopsy of the lesion, the exophytic lesion.
There was an ulcer also, no? In the mucosa, it has come.
Yes, sir. There was an ulceration noted, sir. This is the mass lesion, sir. The liver is mass occupying here, sir.
No, it is okay.
We also did a CT chest, sir, and they wanted to rule out mets to the lungs, sir. They the final report was given as a tiny ground glass nodules, query pulmonary metastasis. A CT guided biopsy was then followed, sir. Gastrointestinal stromal tumor came as the final report, and it showed neoplastic cells which are but the mitosis is 0 to 1 per high power field. We ran IHC markers, sir, of which 2 have come through. CD 117, which is positive, and S100, which is negative. With this in mind,
kindly Samsung XM phone, please mute yourself. Samsung XM phone.
we have sent the cell block for mutational analysis at present, and we are waiting for that. With all of this under consideration, we proceeded with beginning neoadjuvant chemotherapy for the patient, and we started the patient on tablet imatinib mesylate 400 milligrams once in a day, and at present the patient is on his first month of imatinib.
This is neoadjuvant chemotherapy.
Sir, this chemotherapy is more like chemotherapy for trying to reduce the tumor bulk, sir, tumor burden rather.
Will it be called as chemotherapy or not? I'm just asking that. Imatinib is a chemotherapy.
It is more of a monoclonal antibody, sir.
What
Dr.
do you call that?
Dr. Vishashini, please mute yourself. Dr. Vishashini, please mute yourself.
Sir, it is a biological agent, sir, a monoclonal antibody targeted at tyrosine kinase.
Yeah, so that is a targeted therapy, is it?
Yes, sir.
Okay. Yeah.
Targeted chemo.
All right.
His
Do you understand with
Markers,
CD? Ruben, what is CD?
sir,
What is CD?
CD stands for what?
was not able to find this answer. I was actually searching for this answer, sir.
It is cluster differentiation.
Okay, sir.
Okay, CD stands for cluster differentiation.
Yes, sir.
What are the other tumor markers for this?
Sir, in CD117 is the most common, sir, followed by CD34. We have S100.
What
We
is
have
most important CD
Dog
marker?
one.
What is dog one?
Dog 1 is at present recent, along with the PDF GR alpha, sir.
Dog one is the most significant. What is dog one stands for? What is the expansion of dog one? Discovered on GIST. Discovered on GIST.
Ruben,
So that is
how do you
important
assess the
here.
malignant potential of a GIST?
Ma'am,
The lesion
malignant-
that you are dealing with, how will you, what in your investigation suggest whether it's more of benign or more of malignant. So in other words, what are the parameters to judge the malignant potential of gastrointestinal stromal tumors?
Ma'am, there is as per NIH, there is one modified criteria by Johnsu, a pathologist, who graded GIST on the basis of the tumor size and then the mitosis.
So what is the cutoff point in what is the cutoff in size? Where it would be
more than
more
5
than
centimeters.
5
more than 5
centimeters,
itself is
right?
means
Okay.
and more than 10 mitosis more than 10 is significant, ma'am.
More than, you have to speak it full, more than 10
10 per high for
mitosis per 50 hyperfield, per 50 hyperfield, right?
yes, ma'am. And also if there's a ruptured tumor, it upscales the risk.
And CD34 is usually positive. CD34 in
If-
60 to 70%.
Ma'am.
And as sir said, DOG.
In case
So
yes,
you
ma'am.
have nowadays you have got a CD17 which you have done, right? So if it is positive, you have no problem.
Yes, sir.
If it is negative, then you have to run a battery of IHC,
Yes, sir.
dog1, K9, and all those things which are PDGFR. So it is only the problem with the negative cysts, CD17 negative. Okay. Yeah. If it is c-KIT, that is CD17 positive, you have no problem. Right? You can diagnose it straight away.
I did look up into further treatment aspects. That is, if there is imatinib recalcitrant tumors.
You initially said about the staging of the GIST, no?
Yes, sir.
What is that staging and what is the peculiarity of the staging of the GIST?
Sir, in this case, I looked up the NCCN guidelines, sir. For this patient, the tumor was more than 10 centimeter in greatest diameter, sir, with nodal metastasis and with omental metastasis.
No. What is the importance of DCT staging here? What is the peculiarity of the staging? You suppose this is arising from the stomach, but GIST, and what is the main important difference in the GIST staging and the carcinoma stomach staging? What is, suppose it's a T1, N1, what is the stage GIST will be?
It should be stage 4 disease.
So remember, there are only few tumors which can be T1, N1 will be stage 4.
Yes, sir.
Sarcoma and the GIST, stromal tumors. Even if it is a very small tumor, if you are having a node, positive node, that automatically take it to the stage 4. But if it is a stomach carcinoma, T1, N1 is stage 1 only.
Yes, sir.
So here we are going to look in the GIST mainly on that. And the grade, depending upon the low grade or the high grade, that you are going to make the stage. And malignant potential and also the site it involved. If it is a upper stomach, or if it is a colon or the lower end, if it is involved, so they are more severe in the nature in which you are going to treat with the more in terms of the malignant potential.
Yes, sir. This was the guideline. That is, sir.
No, that all we don't. You need not put in the like here. No, this is not a discussion part from your side, like a paper presentation.
Yes, sir.
So in the presentation here, only the exam presentation. So what you have done for the lung metastasis?
Sir, we have not intervened for it, sir. We have not done a biopsy as such. We have not intervened for it at present, sir.
So there is a liver also. There is a nodule.
Yes, sir.
So what is your plan?
Sir, at present, we are giving imatinib, sir, and we will review and sir, imatinib 400 milligrams once in a day, sir. Initial period. Imatinib mesylate is a tyrosine kinase inhibitor, sir.
How long you have to give?
Sir, ideally, it can span for a year, or it can even be for a break period of 6 months, followed by reassessment to see for the decrease in, based on RECIST criteria for the shortest diameter length reduction, and to see whether it is responding to the intervention. And our plan is to go forwards with a debulking procedure.
What is the latest guidelines on R0 resection and R1 resection for GIST?
Sir, at present, we have to target only for an R0 resection, sir. Microscopically, there should be no margin, sir.
Go and refer. Now the reports are coming. In a GIST is one tumor where you are the rest of R0 or R1 resection. Both are identical. The disease recovery and the surveillance period. There is no need to go for a R0 resection in a GIST tumor, especially a tumor like this. If you are going, and even if you can do an R1 resection, that is enough.
Okay, sir.
But you will continue with the tyrosine kinase inhibitor, imatinib for the 3 years, but close follow up you have to only make that.
Yes, sir.
I think we are almost we are crossing that time. Anything you sir, Professor Somasekhar Basu sir, anything you want to ask, or we'll
No,
close
sir.
this?
I think if you can ask the candidate if he wants to ask anything.
Yeah, please. Ruben,
Yes, sir.
Gayatri madam is there. Your madam HOD is present or not?
Sir, I'm not sure, sir. I have to check the panel. Yes, sir.
But which tumors will not respond to imatinib mesylate?
Sir, those which are CD34 positive and those which are PD, GFRA, alpha positive also may not respond to imatinib, for which we need to think of a second line or a third line therapy. Second line being sunitinib, and the third line, sunitinib and dasatinib are both there, sir. And third line is starts with R. It's very difficult to pronounce, sir.
Which respond better to imatinib?
CD117
positive or negative?
sir. Positive, sir.
And those who are negative, 117 negative, do they respond to?
We can attempt sunitinib and see if there is a disease response, sir.
How is sunitinib classified?
Sunitinib.
Imatinib mesylate is a tyrosine kinase inhibitor.
Sir. It belongs.
Can you give an example of multi-kinase inhibitor?
Sir, sunitinib is a it is a multimodal. It does have multimodal. I believe 4 pathways it inhibits, sir.
Okay. Thank you, Ruben. Thanks, sir. Thank you.
Ruben,
Sir,
finally, what is that GIST? It's arising from which cell?
Sir, from the interstitial cells of Kajal, sir.
What is the function of that cell?
Sir, it is responsible for maintaining this the peristalsis, sir, and myenteric plexus, the peristalsis, sir.
So it is not responsible.
Pardon, sir?
Not for the peristalsis. It modulates the central neurogenic activity on the bowel. Okay.
Pacemaker.
Noted, sir.
Understand? It is decided like 3 or 4 for the stomach, 10 for the duodenum, 11 for the small bowel, 4 for the colon, like that. It wherever the central vagal or central sympathetic function is coming down, it at a local level it modulates and sets the pacemaker. Okay.
Ruben, and for which malignancy is imatinib mesylate the sheet anchor of treatment?
Pardon, sir?
For which malignancy imatinib mesylate is the sheet anchor in the treatment?
Is what kind of sir? I do not understand your question, sir. It's the
No, other than GIST. For which other malignancy is imatinib mesylate the sheet anchor of treatment?
You can use an APML, sir. Acute promyelocytic leukemia.
Okay, CML also, chronic myeloid leukemia also.
Yes, sir.
Okay. Okay. Thank you, Ruben. Thanks.
Thank you, sir. Thank you, sir.
Do you have any question, Ruben?
Sir, if I encounter a similar lesion another time, sir, what do I do when it comes to finding the extent of the tumor clinically, sir? How do I, like if I do encounter this as a long case, for example, an epigastric mass that is this large?
What we are looking at the inspection, that is the size you are going to mention. When you are going to palpate, if the size is going to expand, there's no need that an inspection and palpation has to be the same. Especially the mass like this, you are going to feel the upper border, more you are able to palpate. Secondly, like generalized is saying that it is going big in the costal margin, it's not true, because in this case, obviously, we are seeing that different. Your presentation and this should be little more widespread, more focused, not because there's a problem with when you know the diagnosis, you will tend to focus on that. In the examination, you will not have that difficulty. You will have multiple options you have to present, especially scar description has to be a little more careful.
Noted, sir.
Otherwise, fine, you have done well done.
And in all
Well done.
abdominal lumps, the first investigation is the ultrasound. Okay.
Okay, sir. Got it.
Okay. You must keep in mind. You know?
Yes, sir.
If you are sure about that, it's an incisional hernia, it is okay. But if there is a doubt about any lump which is there in the abdomen, you have to do the ultrasound as the first diagnosis.
Yes, sir. Thank you, sir. Thank you, sir.
Thank
Also,
you,
you don't
Ruben. You
have
can
to
be
be-
there.
Yeah, and one more point. Also, you don't have to say to stage the disease when your diagnosis is not yet confirmed.
Okay, ma'am.
Anna?
Thank you, ma'am.
Thank you. Now we will call Merlin Premsi. You can be there. You can please
Yes, sir.
sharing. You want to do the sharing. Dr. Merlin,
Yes, sir.
you can share your screen.
Yes, sir.
You can introduce your chief and HOD and start.
Yes, sir. Yes, sir. Good evening, sir. Good evening, sirs and ma'am. I'm Dr. Merlin. I'm a third year postgraduate student from Department of General Surgery in Tirunelveli Medical College.
They are not seeing you. They are not seeing your picture.
Yes, sir.
So your video you are not seeing. Okay.
Yes. I'm a third year postgraduate from Tirunelveli Medical College, and my chief and HOD is Dr. Babita Devi, ma'am. I'll be presenting a case of gastric outlet obstruction today, sir. Shall I continue, sir?
Go ahead. Go ahead.
Yes, sir. So my patient, Mr. X, he's a 49-year-old gentleman. He's a manual laborer by occupation from Sivagiri, from Tirunelveli district of Tamil Nadu. And he presented with complaints of abdominal pain for 2 months and vomiting for 15 days. So this patient was apparently normal 2 months ago, and then he developed abdominal pain, which was insidious in onset and located over the upper abdomen, and it increased in intensity over the past 15 days. The pain was intermittent in nature, radiating to back, and occurred 2 to 3 hours after a meal. The pain was noticed more during night time, and the pain was relieved by vomiting. The patient has a history of vomiting for the past 15 days, which is spontaneous, preceded by nausea and abdominal pain, and the vomitus contained partially digested food, and it was not bile stained or blood stained, and it was not foul smelling. The vomiting occurs about 2 to 3 times per day, about 3 hours after food intake, and the pain is relieved by vomiting. He has no history of hematemesis and melena. The patient gives history of ball rolling movements over the upper abdomen. He has history of constipation, and he passes hard stools with difficulty once in 3 days. And patient gives history of loss of weight, about 5 kg in the past 2 months. He has no history of loss of appetite, no history of early satiety, no history of abdominal distension, no history of yellowish discoloration of skin and eyes or high colored urine, and he has no history of chest pain and shortness of breath. And past history, patient gives history of similar episodes of abdominal pain on and off over the past 2 years, for which he was taking drugs over the counter, and he has not consulted any physician. He has no previous history of diabetes mellitus, hypertension, bronchial asthma, tuberculosis, epilepsy, cardiac diseases, or thyroid disorders. He has not had any previous surgeries, and he has no previous history of corrosive intake. And personal history, patient consumes mixed diet with increased intake of spicy food. He has no history of smoking or alcohol consumption. Family history, there is no history of similar complaints in his family members. So summarizing my history, a 48-year-old gentleman presented with complaints of abdominal pain, upper abdominal pain for past 2 months, which increased in intensity for the past 15 years, with the pain occurring 2 to 3 hours after a meal and more during night time, and vomiting containing partially digested food particles 3 hours after a meal, with history of ball rolling movements, constipation, and significant loss of weight.
Yeah. Your name, Doctor. What's your name, Doctor?
Dr.
Merlin.
Merlin, sir. Yes, sir.
Yeah, Dr. Merlin. So the
Can you elaborate on the
patient is
vomiting part?
having vomiting. Right?
Yes, sir.
So by how will you distinguish whether this vomitus is from the esophagus or the stomach or the duodenum? By history.
Yes, sir. If it is in the case of esophagus, the vomiting will occur immediately or with a short time after food intake, and it is more like a regurgitation.
No,
And
what about
but
achalasia? What about achalasia?
in achalasia, sir,
Will
the
the
food gets
vomitus happen immediately after eating food?
no, sir. In
Yeah.
achalasia, the vomiting happens like during evening or towards the end of the day, and it is foul smelling.
Right.
And it contains both. It contains undigested food particles.
So what about gastric then?
So gastric, the vomiting occurs about 1 to 1.5 hours after food intake, sir.
In gastric outlet obstruction, it will happen 1 to 2 hours after taking food. What happens in gastric outlet obstruction? Is the stomach dilated?
Yes, sir.
So will the vomiting happen after a couple of hours after taking food?
No, sir. Because
Then-
of the dilated stomach.
So how will you distinguish? How will you differentiate between esophageal and gastric vomitus? You've told me the point, but you have not. You've told it without knowing it. Look, the stomach contains
So it's
usually acid.
acidic, sir. So
Right.
it
So the
hinders the production of development of bacteria. So
So
stomach
there'll be no bacteria in the gastric,
gastric
right?
vomitus. Yes,
While
sir.
it will be foul smelling in the esophageal.
Esophagus.
Also,
Yes.
when they vomit, the floor will be stained with acid,
Yes, sir.
won't it? And
Yes,
in
sir.
esophageal, it won't.
It won't. Yes, sir.
So you have to decide. And what about duodenal?
So, and
It would usually be bile. This would be these two will be non-bilious. Post
yes, sir.
antrum, post pyloric, it would be usually bilious.
Yes, sir.
So can you get a foul smelling in a gastric outlet obstruction?
Yeah,
So
can you get?
Yeah, yes, sir. Due to prolonged stasis, you might
No.
get.
So it will not be 2 to 3 hours after.
Yes, sir.
After a prolonged stay. You have mentioned as a colicky pain. How do you get a colicky pain in this case? Only explain the colicky pain. What is colicky pain?
The colicky pain is it's an intermittent type of pain. It usually occurs in hollow viscous in case of obstruction due to the peristalsis of the organ, sir.
So this patient has no ball rolling movement, no. When you are expecting a colicky pain in a gastric outlet obstruction.
Sir, I'm sorry, sir. I was supposed to change it, sir. I didn't forgot to edit it, sir.
Okay.
I've written as it is intermittent in nature, sir. I've changed it in the next week, sir.
No, you have mentioned as a colicky pain. You changed it.
Yes, sir.
Okay, fine.
Yes, sir. I mentioned it as colicky previously, sir, but then I corrected it, sir. Yes, sir.
The pain was more during night time.
Yes, sir.
He's not taking foods in the daytime. And you are saying that is related to the food habit also.
Yes, sir. Patient, during the daytime, patient experienced the pain 2 to 3 hours after meal, sir, but the pain was more appreciated during the night, sir, after dinner. That's what the patient gave the history like that, sir.
So it's a duodenal ulcer pain.
Sir, based on this point, I am thinking of a duodenal ulcer, sir.
But it is only a 2 months duration.
Yes, sir, but patient gave a history of abdominal pain on and off over the past 2 years, sir.
But you are saying patient is apparently normal 2 months ago.
Yes, sir. This episode started 2 months ago.
Patient is giving a complaint. You think pain abdomen is normal. So your history, you should have included all that.
Yes, sir.
Not to the patient, chief complaints you are mentioning for that. But you must say that the patient had sir complaints 2 years back.
Yes, sir.
Then only it's a correlate to you will be able to explain it.
Yes, sir. Yes, sir.
Because all that you are putting the things with the for the 2 days from 2 months problem.
Yes.
Dr. Marilyn, what is
Yes,
meant by periodicity of pain?
Sir, alternating periods of abdominal pain followed by patient will have a period of pain followed, then the pain will pain will go off. This is a
in which
feature of peptic ulcer disease, sir.
So
What
you have not brought this out in this patient. Is this, does this patient have periodicity involved here in the pain or not?
The patient had about 3 episodes in the past 2 years, sir.
What was the
Each
period?
lasting for different durations, sir. And patient did not give a clear history of periodicity, sir. He took drugs over the counter and it settled in 2 to 3 days, sir. So there was could not elicit the history of periodicity, sir.
What are the things you have not described about the vomiting in this patient? Like you have written everything in the history of present illness. So what are the points that you have not described and you would like to correct now in your description about the vomiting history?
It was not projectile. I would like to add that. Yes.
So what is it, was projectile or non-projectile?
The vomiting was not projectile, sir.
Not projectile.
Yes, sir.
What it was the bile stained or not bile stained?
It is not bile stained, sir.
Okay. And how long after? So in which situations can you get a non-bile stained vomitus?
Sir, when the site of obstruction is proximal to the second part of duodenum, sir, that is in gastric outlet obstruction, or in case of a duodenal stricture, the vomitus is not bile stained, sir.
Okay, that we got. Any other condition in which you get non-bilious vomiting?
Sir, in infants, congenital hypertrophic pyloric stenosis in infants is associated with
Okay.
non-bilious vomiting, sir.
In adults?
In adults,
Maybe in association of some other etiology.
sorry, ma'am, I don't know.
Ureteric colic, what type of vomiting you have? Appendicitis, what type of vomiting you have?
What sort of vomitus will be there in obstructive jaundice?
Yeah, obstructive jaundice, yes, it won't be bile stained.
All these are conditions in which you will get non-bilious vomiting. Okay.
Yes, sir.
Why there is vomiting in ureteric colic?
The
Why do you
not
get?
registered, sir.
It's a reflex pyloric spasm. All are supplied by the same vagus nerve. The sympathetic reflex pyloric spasm for any structure which is being with the vagus, you will get a reflex pyloric spasm.
Yes.
Why do you get pain after 2 to 3 hours? And how do you explain that?
Pain.
He's taking food. You are saying after 2 to 3 hours of taking food, he is getting a pain.
Yes, sir.
What is the? How do you explain it?
Sir, I could explain this like in a case of duodenal ulcer. The pain develops after the gastric emptying, so after 2 to 3 hours. So
it enters the duodenum. Food enters the duodenum.
Yes,
but your presentation, you are saying it is a gastric outlet obstruction. Food is not going there.
Yes, sir.
Then why do you get pain? So certain things we are missing in the history, which you have not gone in detail. So you, because you started presenting as a gastric outlet obstruction.
Yes, sir.
You are saying it is a 2 to 3 hours after the pain is coming. And it is nature of the pain. Probably you would have asked the history earlier. Patient might have had the similar complaints earlier, and now the symptom is different, or what kind of changes which is taking place. Oh. Any other features? I mean, okay, you come to the general examination. Go ahead.
Yes, sir. For general examination, after obtaining consent, the patient was examined in a well-lit room in the presence of a male attendant. The patient is alert, conscious, oriented, and afebrile. He is moderately built and moderately nourished. His hydration is fair. Mild pallor was present. There is no icterus, cyanosis, clubbing, pleural edema, or lymphadenopathy. And vitals, his blood pressure was 110/70 millimeter of mercury, measured in right arm in sitting position. And his pulse rate was 78 per minute, regular in rhythm and normal in volume, and it was measured in the right radial artery. Respiratory rate was 17 per minute, and his temperature was 99 degrees Fahrenheit. So on inspection, his abdomen was
General
scaphoid.
examination,
Yes, sir.
when you are
Sorry.
suspecting gastric outlet obstruction, what are the things you will look for? The previous slide?
Yes, sir. I will look for the hydration status of the patient, sir. Because of persistent vomiting, I would expect him to be dehydrated.
So here the patient is at normal.
Yes, sir. I have examined the patient in the ward, sir, after admission, sir, after 4 to 5 days after admission, sir. So he was treated with IV fluid, so his hydration status was fair, sir.
During examination, IV fluid is on flow?
No, sir.
What are the abnormalities you will get in that? Metabolic changes. Okay, we'll discuss it later. Go ahead for the examination.
Yes. So on inspection, his abdomen was scaphoid with fullness noted over the epigastrium and left hypochondrium. Umbilicus was normal in position and inverted. All quadrants moved equally with respiration. He had a scar of circular in shape of about 2 × 2 centimeter size over the epigastrium to the left of the midline, and papillomata skin lesion was present over the suprapubic region. And visible gastric peristalsis was seen. No cough impulse in the inguinal region. No fullness in the renal angle. Supraclavicular fossa appeared normal, and external genitalia was normal. So shall I move on to palpation, sir?
Yeah, finish your things.
Yes, sir. Yes, sir. So this is a video of the visible gastric peristalsis.
So to watch this, Merlin, to observe this, where should you be standing?
Sir, ma'am, I should be standing at the foot end of the patient, ma'am. But I was not able to capture it properly from the foot end, ma'am. That's why I've taken the video at this angle, ma'am.
Yeah, that's correct. That you should be standing at the foot end of the
Foot end
patient
of
to
the
observe.
patient.
Yeah.
Yes.
You will be standing and seeing an eagle's eye view.
I'll be seeing it at the level. I should lower my eye level to the level of the patient's abdomen and watching it tangentially from the foot end, sir.
If you are lowering your eye level, that means the eagle's eye view. From above, looking down. You have to lower your head down. You have to sit. You are not standing at the foot end. So sit at the foot end and see in tangential view, not at the view of the above.
Yes. Yes. On palpation, there was no localized rise in temperature, and tenderness was present over the umbilical region about 1 centimeter to the right of the midline at the level of the umbilicus. No mass was palpable. Liver and spleen were not palpable. Renal angle was normal. Left supraclavicular fossa was free, and external genitalia were normal. On percussion, The reverse span was 13 centimeter along the mid-clavicular line. There was no shifting dullness. On auscultation, succussion splash was present and normal bowel sounds were heard. In ausculto percussion, the stomach was dilated. The greater curvature of the stomach lay just below the level of the umbilicus. And digital rectal examination, the sphincter tone was normal. The rectal mucosa was normal. There was no mass palpable and the normal fecal staining. And other systems, examination of other systems, cardiovascular system, S1, S2 were heard, no murmurs, and respiratory system, normal vesicular breath sounds were heard, and in the central nervous system, there was no neurological deficit. Yes. So, based on the above examination and the history, I came to the provisional diagnosis of a case of a gastric outlet obstruction due to a benign cause, probably due to a cicatrized duodenal ulcer.
If you are not able to see the visible gastric peristalsis, how do you
Yes, sir.
initiate that?
I'll ask the patient to drink some water, sir,
Mhm.
and tapping on the gently tapping on the anterior abdominal wall also helps to elicit the peristalsis, sir.
So if you have to do the ausculto percussion or you have
Yes,
to
sir.
hear the suction splash and you have to do the visible gastric peristalsis, which one you will do first?
Sir, I will do the succussion splash first, sir, and ausculto percussion, and then I would elicit the visible gastric peristalsis if it is not seen first.
What do you see in the visible gastric peristalsis?
Sir, a wave of peristalsis which moves from the left hypochondrium towards the midline and to the crosses to the right, sir.
Then
Um,
what happens?
Then when it reaches the level of obstruction, the wave then it goes back, and then again the next wave of peristalsis starts, sir.
So this wave is ending there.
Yes, sir.
So what the foot he is taking, how the wave is there, the mass or it is moving with the foot end, no? Foot bolus. That is reaching
Yes.
the duodenal end. It is not going through the duodenum. Then where it is disappearing?
It will go back. It goes back to the stomach, sir, because
It's already in the stomach. Okay. So because the stomach will be dilated in those cases continuously, so it will slowly diffuse back into the greater curvature region.
yes.
And you will not be able to appreciate the.
Okay.
When the next wave comes, again it starts.
Yes, sir.
Suppose like any movement you are seeing left to right.
Yes, sir.
This one, right to left, if there is a movement. What
Yes,
do you
sir.
suspect?
It might be intestinal peristalsis, sir.
Industrial pressure to and fro. You will see right to left and left to right. You are
The
seeing only left to left.
peristalsis. Yes, sir. In a case of transverse peristalsis in the transverse colon, it occurs from right to left, sir.
It will go. If there is, you have an obstruction in the descending colon.
Descending colon.
You may have a VIP only from the right to left instead of left. You have a case, patient has a good VGP, another patient
Yes,
has a low VGP or mild
Yes, sir.
VGP. Which one you
Yes.
think it is more chances of benign?
Patient with more pronounced VGP, sir.
Why?
Sir, because of the distended stomach, the VGP will be more pronounced in a case of benign.
Not a distended stomach.
Sir?
In a malignancy, the muscles will be infiltrated. So it
Yes,
loosens
sir.
to make
Yes,
the contraction. You need forcible contraction.
Yes, sir.
In a benign condition, there is no muscle involvement. So you will get a good VGP for it. You couldn't feel any mass.
No, sir. I was not able to palpate any mass, sir.
Can you go to the inspection slide?
Yes. Sir. Yes. Sir.
What you are inspecting?
Sir.
What you are inspecting? So never
Sir.
just like an inspection. You must be always mentioning what area.
Inspection of abdomen. Yes, sir.
So whether you are going to do the inspection of abdomen or inspection of the inguinal scrotal region, inspection of
Yes,
the
sir.
neck and neck region. So always you write and
Yeah.
mention. And what is
Inspection of abdomen.
left supraclavicular fossa?
Sir, in case of abdominal malignancies, we will look for the left
What is the
supraclavicular.
different anatomical boundary of supraclavicular fossa?
Sir, I will look between the two heads of the sternocleidomastoid, sir. Above, inferiorly bounded by the
The rest of
clavicle.
the supraclavicular region is called, that is not fossa. Posterior triangle, is it a supraclavicular region?
Yes, sir. Hmm.
So what is your focus here? Are you going to witness the?
Sir, I want to mention about the supraclavicular lymph nodes, sir. I want to mention that there was no fullness seen in that
What
area.
I am telling you.
Yes, sir.
Level 4 is also supraclavicular lymph node. Level 5 is also supraclavicular lymph node. Which lymph node, which group of lymph node you are interested in? Level 5 or level 4B?
Level 4B, sir. Not level.
That
Level
is
5.
only the two heads of the.
Sternocleidomastoid, yes, sir.
Okay. What is that scar? You said some circular scar of 2 into 2 centimeter.
Patient had a burn injury during his childhood, sir. So that scar, it's a scar of the burn, sir.
Okay, next slide.
Yes, sir.
Again, next palpation.
Yes, sir.
Okay. So you have no local rise of temperature, but tenderness present in the umbilical region.
Yes, sir.
How will you explain that tenderness?
Sir, I would explain this like the patient, the stomach of the patient was distended, so he was probably experiencing pain around the duodenum. Because it was distended and low lying, it was seen over at the level of umbilicus, sir. And there was no there is no active inflammation, active inflammation, so I'd say there is no local rise in temperature, sir.
So tenderness is due to?
Sir, no local inflammation, sir. No inflammation in the abdominal wall, so I could not. There is no localized rise in temperature.
Marlene.
Sir.
Yeah. So whenever you mention you find an abdominal tenderness, right?
Yes, sir.
You have to mention whether GARD or rigidity was present or not.
Yes, sir.
Okay. Because
yes, sir.
That immediately indicates that there is a visceral problem. The peritoneum is getting irritated.
Yes,
right?
Sir.
So that excludes from even
Yes,
by a small thing, you can exclude many other pathologies.
Yes, sir.
And whenever you are trying to find out, you have specifically mentioned 1 centimeter right of midline. Is it
Yes,
a point or the whole area is the tender?
Sir, it was a point tenderness, sir.
Point tenderness. So that means
Yes,
it's a
sir.
deep tenderness. You have elicited
Yes,
a
sir.
deep tenderness, which is known as the duodenal point,
Yes,
if I'm
sir.
not wrong. Trying to insist, trying to, focus that it was probably a duodenal ulcer which you had been thinking of. Am I
Yes,
right?
sir. Yes, sir. Yes,
Yes.
sir.
So especially that happens when there is no gastric outlet obstruction. The duodenal point is more or less fixed.
Yes.
But when there is a gastric outlet obstruction, the stomach becomes so huge, especially to that point anatomically it doesn't remain there.
Yes, sir.
So if you find a tenderness during palpation without any muscle guard or rigidity, that's probably something which you are not significant, which you are dealing with.
Okay, sir.
Okay, so you have to mention
sir.
that. Tenderness
Yes, sir.
present in the umbilical region without any muscle guard or rigidity.
Yes, sir.
Hmm.
Yes, sir. I should
The
have
renal
mentioned.
point, I think, is in the transpyloric plane.
Yes, ma'am.
I think 2.5 centimeter to the right of the midline in the transpyloric. Huh?
Yes, ma'am. Yes, ma'am.
Will not be near the umbilicus, so down. Even if the stomach is distended, duodenal point will not be pushed down.
Okay.
So you are calling it a gastric outlet obstruction.
Yes, sir.
Why is it not a gastroparesis?
Um,
How to differentiate between the two?
Sir, I'm not sure, sir.
What is gastroparesis?
Delaying the gastric emptying, sir.
That means the stomach is not contracting.
Yes, sir.
There is some
Here you are
neurological
having
problem.
Here, because of the visible gastric peristalsis, the peristalsis of the stomach is present, sir.
First in the history. What comes in the history?
Here it's still ball rolling movements, sir.
No. What is the vomitus?
Vomitus was not bile stained.
Not bile stained. If you have vomitus is not bile stained, so it is a mechanical obstruction, not a gastroparesis. Okay?
Yes. Yes,
because
sir.
it is not obstructed, the pyloric canal, right?
Yes, sir.
So one very important significant point to differentiate between the two is whether the vomiting is containing bile or not. And the second
sir.
is visible gastric peristalsis.
Hmm.
Others will get succussion splash, osculate percussion, a huge stomach in both the conditions.
Okay, sir.
Yes. So you have to very clearly differentiate one from the other.
Okay,
In
sir. Yes, sir.
gastroparesis, the stomach is completely relaxed. It is stunned. It isn't moving. It will manifest in the same way as the gastric outlet obstruction. Patient will vomit, copious vomiting containing old food, and all those things. Everything will be there, right? But the bile
Yes,
will
sir.
also be there, and you'll not be able to find out ball rolling movement, that gastric contraction.
Yes, sir.
Is the boundaries of renal angle?
Sir, superiorly by the 12th rib, sir. Below by the latissimus dorsi, and medially by the paraspinal muscles.
So why do you want to look for renal angle?
Sir, to look for any renal mass or swelling in the area, sir. In case of tenderness, sir. In case of pyelonephritis or
You done the
hydro-
percussion on that region?
Sir,
Percussion.
percussion.
Normally, if you are percussing on renal angle, what will be the tone you will get?
Dull.
Dull.
Why do you get dull
How it
tone
is
normal?
Then how can it be normal?
Why normally you will get a dull tone?
Sir, it corresponds to the position of the kidney, sir.
Oh, what
So-
is the posterior structure on which the kidney lies? What is the kidney bed? Kidney is lying on what structure?
What do you get posterior to kidney? Is it? What is there in the abdomen other than kidney?
Sir,
You tell the kidney when you approach the kidney from behind. What are
Yes,
the
sir.
things which what is there behind the kidney? The bed of the kidney. Muscles are there. Two muscles. What are
muscles,
they?
yes, sir.
What muscle?
psoas and psoas
And
major,
psoas
quadratus.
and quadratus.
Yes.
So there are two muscles behind the kidney,
Yes, sir.
and the lateral boundary of the sacrospinous muscle is more than that. So kidney normally never comes in the renal angle.
Yes, sir.
So what will be the percussion note of normal person, a patient who doesn't have a normal person?
Not enlarged, it is only normal.
Yes, it will be resonant
Resonant. Why?
because
Only
of
when it is
the-
resonant, it is normal.
Yes, sir.
If it is dull,
So why normal should be resonant?
Mm,
What will be there which will produce the resonant note? There is some vowel will be there.
yes, sir.
Which vowel?
Transverse. The transverse colon, sir.
No, the colon is anterior to kidney.
Yes, sir.
So you'll never get it. The colon there. Which vowel is there all over the abdomen?
Small.
Small vowel. So this is the presence of the small vowel loops, which will give you the percussion note as
Yes.
resonant. Only when
Yes.
the kidney is enlarged, right? Only when the kidney
Yes.
is enlarged, it encroaches in the renal angle. You'll get a dull note. And
Yes.
dull note in the renal angle is almost sacrosanct. That means you can confirm yourself clinically that you're dealing with a kidney mass.
Oh,
Okay?
yes. Okay.
you have examined the correct examination. Next, right? What is that sphincter tone? Not normal. What tone you have examined? Which
Sir?
tone you are examining? How many tones are there for the anal
Yes, sir.
sphincter?
Sir, it's been tone of the external anal sphincter, sir. Rest.
No, sphincter tone has two tones. Sphincter. Which tone you have examined? Resting tone or squeezing?
Resting tone.
Resting tone is maintained by?
Internal anal sphincter.
What is the external sphincter maintaining what tone?
The squeezing tone.
Squeezing tone. So it is normal.
Yes, sir. Both are normal, sir.
So what is your provisional diagnosis? You are thinking in terms of duodenal ulcer.
Yes, sir.
So can you feel a mass in the duodenal ulcer? Cicatrized duodenal ulcer?
Sir, maybe palpable, sir. But
So why do you think this case is having a duodenal ulcer? Because your duration of a history is only 2 months.
yes, sir. Patient is 49-year-old male patient, sir. He's a middle-aged person. And on examination, patient he has no history of loss of appetite or any symptoms of malignancy. And on examination also, visible gastric peristalsis was present and stomach was distended. So probably pointed towards a chronic pathology. So I was thinking of a benign duodenal ulcer with cicatrization, sir.
Projectile vomiting?
No projectile vomiting, sir.
What is the typical vomiting in gastric outlet obstruction?
Non-projectile, non-bilious vomiting, sir.
Non-projectile. So it is
Yes, sir.
induced vomiting in the gastric outlet obstruction.
Sir, I was not able to get your question, sir.
The induced vomiting.
So
When the
induced
patient goes for gastric outlet obstruction, will he produce a induced vomiting or a projectile vomiting? Is it a large amount or a small amount?
Large amount, sir. When it
It's
is
a copious, projectile, false
Vomit.
smelling, vomiting.
yes, sir.
So how you are going to proceed?
Sir, I will proceed with the investigations to confirm my diagnosis, sir. First, I will do an X-ray abdomen erect and X-ray chest Um,
Do
because
you want to
since
take X-ray first?
sir, because patient has tenderness anyway, to rule out any perforation, sir.
You are
Dr. Basu had asked whether it was that tenderness was associated with guarding or rigidity.
Yes,
So that
Ma'am.
would have been
Yes, ma'am. It is
any
not associated with
perforative
guard.
peritonitis would have been ruled out by clinical examination.
Yes,
Isn't
ma'am.
it?
Yes,
chronic
ma'am.
case. Don't bring that mistake. No?
Yes, ma'am. Yes, sir. An ultrasound of the abdomen, sir, first.
What is your confirmation?
So we can we can appreciate the dilated stomach, and if there is
No,
any
confirmation.
mass,
Forget about that. How do you confirm your diagnosis?
sir, I'll do an upper GI endoscopy, sir.
So you have done an upper GI endoscopy?
Yes, sir.
Tell me what findings you will see here.
1 second, sir. Before that, what is the best time to do upper GI endoscopy in such a patient? This patient has come to your OPD today or in your emergency. What is the best time to do upper GI endoscopy?
If I have to plan for an upper GI endoscopy, first I'll insert a Riles tube and give gastric and do gastric lavage, ma'am. So probably 48.
What size?
57.
What size Riles tube will you? Nasogastric tube will you choose?
Sir, a wide bore Riles tube. So probably an 18 gauge.
16.
18, sir.
18. Okay.
Yes. And
How
after
does that help? How does that help in endoscopy? Putting a Riles tube first. You are right in saying that. You're correct, but how does it help?
By emptying the gastric contents, it can help in better visualization, ma'am. And
Yeah, that is one thing. It reduces the edema and the inflammation. So for probably 24 to 48 hours, we put a Riles tube and then we go on to do an endoscopy. Okay.
Yes.
So you have kept a provisional diagnosis of a pyloric stenosis, right?
Yes, sir.
Yes. Now, gastric outlet obstruction can be because of something luminal.
And
some cause can be because of mural.
Or extraluminal, sir.
Or extraluminal or extramural.
Yes,
that means
sir.
outside the stomach, in the wall of the stomach, and in the lumen of the stomach.
Yes, sir.
So with the first investigation as OGD, upper GI endoscopy, you'll only catch the luminal ones.
Yes, sir.
So a screening ultrasound to know what is the probable cause of the obstruction, right? What is the thickness of the gastric or the stomach wall at that region of the pylorus, right? All this information you can get. And when you get a probable diagnosis that you're dealing with a cicatrization or a pyloric stenosis,
yes, sir.
Then you go ahead for the luminal, because you have to, that will only help you to pick up the luminal pathology. Okay?
Yes, sir. Yes, sir.
Similarly, when you have done a gastroendoscopy, you are putting a lot of gas into set. And you cannot do an ultrasound after that, where you will be still wait for a long time to get the gas to be absorbed. So always do an ultrasound first. It has been now almost all the examiners has confirmed. Even for a luminal pathology, the first investigation of choice only ultrasound.
Yes, sir.
Second, then you are localized, as Sarah said, with the mural, extramural, any other lesion. Then you can go for your confirmation in the endoscopy.
Yes, sir.
So you need to do the gastric lavage, prepare the patient, and then you are going for a endoscopy. So what are the things you are going to look there?
Sir, I look for any mucosal lesions, sir, any ulcers present, and the pylorus.
If there is an ulcer present, how do you know it is a benign ulcer or a malignant ulcer?
Sir, benign ulcer is more commonly located on the lesser curvature, sir, and the mucosal rugae will radiate from the ulcer, sir, and malignant ulcer is more commonly located on the greater curvature, sir, and maybe associated with the rolled out edge or everted edge, and also it may proliferative lesion may be associated with the ulcer, sir.
Now, what will
So-
happen to the rugae in case of a malignant ulcer?
The rugae will be the rugae won't converge at the ulcer, sir.
So what will happen to it?
Yeah,
So,
effaced, or ironed out.
Yes,
so you'll not find them going near the ulcer, isn't it?
yes,
They'll be destroyed around the ulcer. You'll not
Ulcer.
find them because the mucosa gets fixed with the underlying malignancy.
anything
Whereas
about,
in case of a, sir,
anything about the peristalsis, anything about the distensibility?
yes, sir. I look for the distensibility of the stomach, sir, because in linitis plastica, the mucosa may be normal, but the distensibility of the stomach is lost, sir. So in endoscopy, I look for the distensibility of the stomach also.
Peristalsis?
Peristalsis.
Will you see, will you be able to go into the duodenum?
In case of, I will, yes, sir. You have to see if the scope can be passed through the pylorus, or if it is scope cannot be passed. In case of a partial obstruction, we may be able to pass the scope with difficulty, sir.
What is the significance if you can pass the scope and not able to pass the scope? You can able to pass the scope, that indicate patient's nutritional deficiency may not be.
Be that severe, sir. Because some amount of food can enter the duodenum.
What are the advances in the upper GI endoscopy? You know,
Sir, narrow band imaging to look for if
what is
even
narrow band?
to-
What is narrow band imaging?
Sir, the blue light is used, sir, to look for any specific wavelength of light is used to look for any mucosal.
Only blue light is used. How many
I'm not
lights in the
sure.
wavelength? You have a red, blue, green, and you don't
Yes,
use
sir.
the blue and green.
Yes, sir.
So, after confirming your diagnosis,
Yes, sir.
what you are going to do?
So since after confirming the diagnosis, if it turns out to be a cicatrized duodenal ulcer, I would proceed with truncal vagotomy or vagotomy with
Right away surgery. Do endoscopy and next morning you will go to the surgery table.
No, sir. I would do the investigations to look for the general status of the patient, sir. Blood investigations and
Will you not give a trial of medical treatment? Straight away decide for surgery.
no, ma'am.
Hmm?
You will give, yes, ma'am. Yes,
You
ma'am.
have to give conservative management. What is that?
I'll start him on proton pump inhibitors. Anti-H. pylori.
And
Ma'am?
What?
Lifestyle modification,
Yes, ma'am.
avoidance of NSAIDs. There are so many things that has to be done first before you jump on to do a vagotomy.
Always go in an order, methodological way. Go approach in a method. Don't right away jump into drug therapy and surgery first. Always lifestyle modification and whatever the things you do. What are the metabolic abnormality you are expecting in a gastric obstruction?
Sir, a metabolic alkalosis, sir, because of the loss of acid through the vomiting, sir.
So what fluid you will give?
I prefer a normal saline, sir, because of loss of hydrochloric acid through the vomitus.
Yeah, but if it is losing hydrogen ions, it is also losing chloride.
Yes, sir.
So
Sir,
what is
I'm
the
not able to.
mechanism? See, if it is losing bases also, isn't it? Alkali. The negative ions are being also lost.
Yes, sir.
Why selectively should the hydrogen ion be lost?
What is that paradoxical aciduria?
Sir, I'm not able to recollect it, sir.
So what is the
Because
problem here? What is the problem?
there is a metabolic
No problem in the pathology.
loss of
So if you keep a patient on Ryle's tube, you mean to say the
Yes,
same
sir.
thing is going to happen? Alkalosis. Here there is a selective loss of the acid without loss of alkali. The alkali, normally what happens? There is a bile reflux. So pancreatic juice and bile enters the stomach. So both are lost. Whenever somebody vomits or you put a patient on Ryle's tube for a long period of time. So the loss becomes both positive and negative ions, acid and alkali.
Yes,
But
sir.
here, the alkali is not coming in the stomach. The loss only happens with the acid. Okay?
Yes, sir.
This is the basic difference in the mechanism.
Okay, sir.
And as a result of which, there is a paradoxical aciduria. So two phases are there. One is a compensated phase, the other is a decompensated phase. Right?
Yes,
You
sir.
have to read up. This is a very important question in
Yes, sir.
exam. If you get a gastric obstruction, this question is really bound to be asked.
Okay, sir.
And you should know the mechanism of paradoxical
Mechanism.
aciduria. How it is.
Yes, sir.
Hypochloremic, hypokalemic,
Metabolic.
hyponatremic.
Yes, sir.
Alkalosis with paradoxical aciduria with intracellular acidosis. This is a complete
What will happen
picture.
to the calcium? What will happen to the calcium?
Sir, the later stages it can cause hypocalcemia also, sir.
Hypocalcemia also.
Yes, sir.
So, what do you think the main cause for this ulceration, peptic ulceration? What is the basic pathology or what is the etiology that you are expecting for this patient?
Sir, hypersecretion of hyperacid.
Acidity, what will happen in a gastric ulcer? You get an acidity, peptic ulcer, you get an acidity. Okay, we go that. What will happen to the H. pylori infection? Can you say the morphology of H. pylori?
Sir, it is flagellated baseless.
No, it is Helicobacter.
Helicobacter.
What is helico?
Helicospiral, sir.
It is like a helix.
It's a gram positive, gram negative. It is motile, non-motile. Oh, you need to study a lot on that.
Yeah.
Yes, sir.
Basic. Because duodenal ulcer, if the case is there, more the discussion will be on the physiology
Yes,
and
sir.
the methodological aspect. What is
Okay,
the test to confirm H. pylori? How will you confirm the H. pylori infection?
Sir, urea breath test, sir.
What is the best and most confirmatory test?
To look for H. pylori in the biopsy, staining.
By endoscopy. Also in the stool.
Yes, ma'am.
You check by the kit, you can check for H. pylori.
Yes.
What is the effect of H. pylori on the stomach?
Sir,
What
H.
is
pylori
What
causes.
is the chorea cycle?
Sir,
Chorea cycle.
What does it do to the urea cycle?
sir, H. pylori, it secretes the urease enzyme and it releases ammonia and causes an alkaline environment and neutralizes the acid to proliferate, sir.
Very good. So you see, what is the treatment of H. pylori infection? They give those kits, isn't it?
Yes, sir.
So what does it contain? Any idea?
It contains a proton pump inhibitor,
And 2 antibiotics.
antibiotics, sir.
2 antibiotics. It is a triple drug, right?
Yes, sir.
So you say it produces alkali, ammonia, and neutralizes the acid so that it can thrive.
Yes, sir.
So in the treatment also, you are giving a proton pump inhibitor. So it will thrive better instead of getting killed.
Sir, because of this because of this alkalinity, the gastrin will
No,
increase.
that's not the mechanism. The mechanism is that if you neutralize the acid and produce a further alkaline medium, these bacteria proliferate more.
Yes,
And
sir.
it's the young bacteria which are killed by the antibiotic.
Yes, sir. Okay.
Okay.
Yes,
So
sir.
to kill the bacteria, you have to allow it to proliferate.
Yes, sir.
And to allow it to proliferate, you have to neutralize the acid. And that's the reason why all these drug combination, triple drug, quadruple drug, everybody will have all types of possible combination. But one thing is very common. The only constant thing is the proton pump inhibitor. Understand?
Yes, sir.
Yeah, you are in the best of centers. You have done lifestyle modification on medical management, this and that.
Yes.
But you also know it's a benign condition. So do you have anything to help this patient without going for surgery?
Sir,
Hmm.
pyloric stenting can be tried.
Yes.
Sir.
Yes. So there's a very good technique which can be done to allow just the normal resumption of the gastric emptying, right? So you can go for pyloric stenting.
Can this H. pylori cause any malignant changes?
Yes, sir. Can cause a gastric lymphoma, mucosal associated lymphoma, sir. Maltoma.
Maltoma. Gastric carcinoma?
No, sir.
It will not produce gastric carcinoma. Will H. pylori cause gastric carcinoma?
I'm not sure, sir.
The commonest cause is that. What is metaplasia? Dysplasia?
Yes, sir.
Chorea cycle?
Oh,
Which H. pylori will protect from a person developing one carcinoma.
it will protect against duodenal.
No. Protect against esophageal because reflux will be lost. It produces achlorhydria. So the Barrett's esophagus and the reflux will be less. What is African enema?
I'm not.
So people who have H. pylori is only there is a particular 2 antigen, VAG-A and VAG-C. In Egypt population, African population, this particular genetic marker is not there. Though they have a H. pylori, they will not have the malignant changes. So now you conclude, then there is a medical management is not responding. And what is your option?
Sir, I will do a vagotomy to reduce the acid secretion and a drainage procedure, sir.
But you are living in a highly advanced 21st century. You will do a truncal vagotomy.
Sir, a pylorus preserving highly selective vagotomy can be done, sir.
Why not you are trying to do a pyloroplasty? And why do you want to do a vagotomy again?
Sir, in case of
you are taking much time.
In case of a duodenal ulcer, the acid secretion occurs during the it occurs due to the cholinergic sir, due to the vagus, sir. So to reduce the acid secretion, we have to do a vagotomy, sir. In case of a gastric ulcer, it is secreted. It depends on gastrin, sir. So it is you can do an antrectomy to reduce the formation of gastric ulcer.
So what vagotomy will do? Can you trace the vagus?
Right.
Can you trace the vagus from where it comes, starts, where it ends?
Sir, I'm sorry, sir. I am not read upon it, sir.
Where it starts, where it ends?
It starts at the medulla oblongata, sir. The center starts in the medulla, and it leaves the brainstem and it exits via the jugular foramen along with the carotid internal jugular vein and the 9th and 11th nerves, and then it descends downwards and it ends as the anterior and it ends along the stomach, sir. As
Ends in
anterior
the stomach. To what level vagus supplies?
till the colon, sir. Where some
The transverse colon. So all that your parasympathetic supply is only from the vagus.
Yes.
As far as never ever try to do the truncal vagotomy, and if you all want, you can only the highly selective vagotomy, only to the particular. And nowadays, with the good proton pump inhibitors and good therapy, that is role of vagotomy is very less.
Yes.
So how will you convince the patient? Or what you are going to do for your patient?
We've actually operated on the patient, sir.
Already operated?
Yes, sir. Today.
What was done?
Ma'am, vagotomy and a gastrojejunectomy, ma'am.
Which vagotomy?
Truncal vagotomy.
Truncal vagotomy.
It is a little obsolete operation. Nowadays, going for a truncal vagotomy is very, very rare. And when you have, and again, more pyloroplasty is much preferred than you are going for a procedure. Okay, you have any questions to be asked now?
No, sir. I have a lot of studies, sir.
Good. You are second year now, just entering into the final year. So you have one more year for you to study, but concentrate more on anatomy and physiology also. Yes. Basu sir, you need your opinions and comments.
You have done fairly good, but what you need to know, as Dr. Jalal said, right, sir has said that the mechanism of the disease is very important.
Yes,
right?
sir.
Mechanism, what is the problem here? So if you do a pyloroplasty, the problem is settled. There's a gastric obstruction, you do pyloroplasty. In the present day, the duodenal ulcer has been converted to is actually understood now as an infective disease, not an acid disease. Understand? Yes, so the treatment of H. pylori, and you have to treat it probably many times because they get infected repeatedly. And because of the presence of the drug resistance patterns which are coming up, so you might have to change antibiotics, various types of problems which are coming up nowadays with the. So just doing a gastrojejunectomy at the same time you're doing a vagotomy. So the vagus takes away the, the biliary function, the gallbladder contractions, and then the motility of the bowel. So those are the days where people did not understand the mechanism of the duodenal ulcer, peptic ulcer, probably, right? So now you have to read about everything about when a gastric obstruction is coming. That means multiple diseases can produce, as you said, luminal diseases, mural diseases, extramural, like carcinoma of the gallbladder can produce gastric artery obstruction, right? So again, this can go to a carcinoma gallbladder also at the same time. Once it goes, and then finally you have to land up with a carcinoma of the gallbladder. So all the possible things which you need to know. Then there is something known as a saline load test, which actually differentiates between an atonic stomach and a mechanical obstructed stomach, right? Read it up. 750 ml of saline is pushed, and then you have to take it, position the patient and take out the saline load test, right? It's still valid. You can differentiate between the two, whether this is a problem with the stomach contractility or the problem with the mechanical obstruction.
It is most confirmatory test, that is.
Yes, it is the most confirmatory, still there in the textbooks, and it has not gone in spite of having so many gadgets and technology around. Okay. Yeah. Good. So read more, see cases more, prepare yourself. It's a good thing you have presented today.
Yes.
Thank you.
Thank you, sir.
And I will, sir, you landed in Chennai.
I'm with you, sir, for the past 15 minutes.
Okay. Yes, able to see Babita. So welcome, Babita ma'am.
Good morning, sir. Good evening, sir. Sir told to present the case yesterday only. She prepared only for one day. Today only she prepared her slides.
Good effort.
That's
Good effort, Dr. Marie. Yeah.
Thank you, ma'am.
Yeah, you've done a very good job. If you have done it in one day.
Thank you, sir.
And always consider the questions or the answers which are discussed here as
Yes, sir.
learning process, right?
Yes, sir.
Because you get to hear so many questions, and then you look up, you prepare again
Yes, sir.
and present in-house in your center, right? Yeah.
Yes, sir.
This is one of the rare case because normally you don't discuss this case in the wards. You have a gastric stomach, you will discuss. Gastric carcinoma, you will discuss. But per se, discussing on the psychiatrist, duodenal ulcer, management, physiology is very important. And all the best. Can I will, sir? Madam?
Yes, sir. I think if we have any other comments from the faculty, else we can call it close, sir.
Thank you.
Thank you. Thank you. Thank you.
Thank you. Thank you,
Thank
esteemed faculty, for joining this Friday. We look forward for yet another Friday. And I'm happy to share we are closing into 5 lakh views. Probably by next Friday, we'd have completed 5 lakh views by the students. Once again, I dedicate to all the consistent effort by all the faculty who have been contributing and the residents who have been contributing for the past 3.5 years. Thank you very much. Good night, everyone.
Thank you.
Thank you, sir.
Good night.
Good night.